This is Emergency Care and Transportation of the Sick and Injured, Chapter 20, Immunologic Emergencies. After you complete this chapter and your related coursework, you will understand the anatomy, physiology, and pathophysiology of hypersensitivity disorders and anaphylactic reactions. Also, you will have the knowledge and skills to recognize and manage hypersensitivity disorders and anaphylactic reactions. National EMS Education Standard Competencies. Medicine as it applies to fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. Immunology is the recognition and management of shock and difficulty breathing related to anaphylactic reactions, anatomy, physiology, pathophysiology, assessment, and management of hypersensitive disorders and or emergencies and anaphylactic reactions. As an EMT, you will often respond to calls involving an allergic reaction. Allergy-related emergencies may involve acute airway obstruction and cardiovascular collapse. You must be able to treat these life-threatening complications. You must also be able to distinguish between the body's usual response to an allergen and an allergic reaction. This chapter describes immunology, which is the study of the body's immune system and the 5 categories of stimuli that may provoke an allergic reaction. The immune system and the body from foreign substances and organisms is what happens when you have a severe allergic reaction. When a foreign substance invades the body goes on alert, and the body initiates a series of responses to inactivate the invader. Let's talk about the pathophysiology involved. An allergic reaction is an exaggerated immune response to any substance. It is not caused directly by an outside stimulus such as a bite or a sting. Rather, it is caused by the body's immune system, which releases chemicals to combat the stimulus. These chemicals include histamines and leukotrienes, both of which contribute to an allergic reaction. Given the right person and the right circumstances, almost any substance can become an allergen. First, the person becomes sensitized, exposed for the first time to the substance. Then his or her immune system learns to recognize the substance. When the patient is exposed to the substance again, an allergic reaction occurs. Some patients may not know what is causing their allergic reaction, so you must be able to recognize the signs and symptoms and maintain a high index of suspicion. An allergic reaction may be mild and local, characterized by itching, redness, and tenderness, or it can be severe and systemic, which is a condition known as anaphylaxis. Anaphylaxis is an extreme, life-threatening allergic reaction. It involves multiple organ systems. In severe cases, it can rapidly result in shock and death. 3 common signs are urticaria, which is hives, and that's a small area of generalized itching or burning that appear as multiple small raised areas on the skin. Angioedema is an area of localized swelling. Wheezing is a high-pitched whistling breath sound that is typically heard on expiration. It results from bronchospasm and bronchoconstriction and increased mucus production. You may also note hypotension due to vasodilation as well as increased capillary permeability. An often overlooked symptom of patients experiencing allergic reaction is persistent gastrointestinal dysfunction, such as nausea, vomiting, and abdominal cramps. Common allergens. The most common allergens fall into the following 5 general categories. Food. Certain foods such as shellfish, peanuts, etc. may be the most common trigger of anaphylaxis. These foods account for 30% of deaths from anaphylaxis, most commonly in adolescents and young adults. The symptoms may take more than 30 minutes to appear and may not include skin signs such as hives. The reaction can be severe and involve the respiratory and/or cardiovascular systems. With medications are the second most common source of anaphylactic reactions, particularly antibiotics such as penicillin and nonsteroidal anti-inflammatory drugs, NSAIDs. If the medication is injected, the reaction may be immediate, within 30 minutes, and severe. Reactions to oral medications may take more than 30 minutes to appear, but can also be very severe. If the medication is injected, the reaction may be immediate, within 30 minutes, and severe. Here's an example of that. Reactions to oral medications may take more than 30 minutes to appear, but can also appear very severe. Dust, pollens, and other plant materials can cause a rapid and severe allergic reaction. Common plant allergens include ragweed, ryegrass, maple, and oak. With chemicals, there are certain chemicals, makeup, soap, hair dye, latex, and various other substances that can cause severe allergic reactions. Latex is of particular concern to healthcare providers. Patients can be sensitive to it, and as many as 12% of healthcare providers become sensitized to latex. Use latex alternatives such as nitrile gloves. Insect bites and stings. When an insect, such as a honeybee, wasp, ant, yellow jacket, or hornet, bites or stings a person, the act of injecting the venom is called envenomation. The reaction can be localized, causing swelling and itching at the site, or it may be a severe and systemic reaction, like anaphylaxis. Approximately 3% of adults and 1% of children are allergic to the venom of bees, wasps, and hornets. An allergic reaction to insect stings account for at least 50 deaths in the United States per year. In about half of these deaths, the victim had never experienced reaction to prior stings. The stinging organ of most insects is a small hollow spine projecting from the abdomen. Venom can be injected through this spine directly into the skin. Honeybees cannot withdraw their stinger. The honeybee flies away and dies. If the stinger is not removed, it can continue to inject venom for up to 20 minutes. Because they fly away, it is difficult to identify which species is responsible. Wasps and hornets can sting multiple times, and they do not die after stinging. Some ants, especially fire ant, can also strike repeatedly, often injecting a particularly irritating toxin at the bite sites. Signs and symptoms are sudden pain, swelling, localized heat, widespread urticaria, redness in light-skinned individuals, and itching and possibly a wheal, which is a raised, swollen, well-defined area on the skin. Applying ice sometimes makes stings and bites less irritating. The swelling associated with an insect bite may be dramatic and frightening. As long as these manifestations remain localized, they are not usually serious. In more severe or anaphylactic cases, patients may experience bronchospasm and wheezing, chest tightness and coughing, dyspnea, anxiety, gastrointestinal complaints, and hypotension. Occasionally, respiratory failure can occur. If untreated, an anaphylactic reaction can proceed rapidly to death. More than 2/3 of patients who die of anaphylaxis do so within the first 30 minutes, so rapid treatment and transport is essential. Patient assessment in an immunologic emergency. Let's talk about scene size up. Scene safety, of course, is of utmost importance. If the patient's environment or recent activity may indicate the source of the allergic reaction, there could be a sting or a bite from an insect, food allergy at a restaurant, or a new medication regimen. A respiratory problem reported by dispatch may be an allergic reaction. Until a field impression of allergic reaction is firmly established, be mindful of other potential causes of respiratory distress. Traumatic injury may also be present secondary to a medical emergency. Follow standard precautions with a minimum of gloves and eye protection. Consider the need for additional resources such as advanced support or ALS personnel. In your primary assessment, quickly identify and treat any immediate or potential life threats. Assess the patient's airway, breathing, and circulation, ABCs, as deterioration can occur at almost any time and with very little warning. ABCs should be reassessed repeatedly throughout transport. Form a general impression. Allergic reactions may present a respiratory condition or as a cardiovascular distress in the form of shock. Patients experiencing a severe allergic reaction will often appear very anxious. If your general impression finds the person anxious and in distress, immediately call for ALS backup if available. Look for a medical identification tag if the patient is found unresponsive or is unable to answer questions. Airway and breathing. Anaphylaxis can cause rapid swelling of the upper airway. You may only have a few minutes to assess their airway and provide life-saving measures. Not all allergic reactions are anaphylactic reactions. Work quickly to assess the patient to determine if the severity of the symptoms and the number of the body systems affected. Quickly assess for increased work of breathing, use of accessory muscles, head bopping, tripod positioning, nostril flaring, and abdominal breath sounds. Wheezing is due to narrowing of the air passages, resulting from contraction of muscles around the bronchioles in reaction to the allergen, and mobilization of mucus in an attempt to push out the allergen. As the patient's condition worsens, breathing may diminish to the point of being almost silent. Stridor, which is a harsh, high-pitched sound heard on inspiration, can eventually lead to total obstruction. The patient may eventually fatigue and may even stop breathing. In the latter case, cardiac arrest will shortly follow respiratory arrest. Assist the patient into a comfortable position, generally in a high Fowler's position, to maximize ventilations. If signs of shock emerge, immediately place the patient in the supine position as tolerated. Listen to the lungs on each side of the chest. Do not hesitate to initiate high-flow oxygen therapy. For a patient in severe respiratory distress, you may have to assist ventilations using a BVM or bag valve mask attached to a high concentration of oxygen. Regarding circulation, some patients in anaphylaxis may present with signs and symptoms of circulatory distress, such as hypotension. Palpate for the presence and quality of a radial pulse. Assess for a rapid pulse rate, pale, cool, cyanotic, or red moist skin, and delayed capillary refill, all of which may indicate hypoperfusion. Treatment for shock. You must provide oxygen. Positioning should be either recumbent or supine as tolerated. Preventing the loss of body heat is important. The definitive treatment for anaphylactic shock is epinephrine. Transport decisions. If anaphylaxis is suspected, or if a relatively mild allergic reaction appears to be worsening, immediate transport is warranted. Take along the patient's medications such as autoinjectors and inhalers. If the patient is calm and does not exhibit severe symptoms, consider continuing the assessment, but err on the side of emergency transport. History taking. Investigate the chief complaint or the history of present illness. Identify signs and symptoms. The table on this slide shows additional signs and symptoms of an allergic reaction. Make sure to take a really good review and look at this particular table, 20-1. It's in your text as well. A sample history. If the patient is responsive, obtain the sample history including OPQRST and ask him or her the following questions specific to an allergic reaction. Have any interventions already been completed? Has the patient experienced a severe allergic reaction in the past? Be alert for any statements regarding the ingestion of foods, that commonly cause allergic reactions. Inquire about the presence of gastrointestinal complaints such as nausea and vomiting. In the secondary assessment, make sure you do a physical examination. If indicated, perform a rapid exam of the body from head to toe or conduct a physical examination focused on the area or areas of chief complaint. If the patient is unconscious or otherwise unable to communicate, remove clothing as necessary and look for the presence of bee stings, sign of contact with chemicals, and other clues suggestive of a reaction. Look for a medical alert tag that could indicate a severe allergy. If you've not already done so, auscultate for abnormal breath sounds such as wheezing or stridor, and carefully inspect the skin for swelling, rashes, or urticaria. If a symptomatic reaction continues, the body will have difficulty supplying blood and oxygen to the vital organs. Altered mental status is one of the first signs. Vital signs. Vital signs indicate whether the body is compensating for the stress imposed on the body by a reaction. Assess baseline vital signs including pulse and respiratory rates, blood pressure, pupillary response, and oxygen saturation. Skin signs may be unreliable indicators of hypoperfusion, as they may vary widely or be hidden by rashes and swelling. Monitoring devices. In a patient experiencing an allergic reaction, pulse oximetry can be a useful method for assessing the patient's perfusion status. The decision to apply oxygen should be based on airway patency, the work of breathing, and abnormal lung sounds on auscultation, not solely on pulse oximetry readings. Reassessment. En route to the hospital, repeat the primary assessment, reassess the patient's vital signs, and repeat a focused physical examination of the affected body systems. If the patient is unstable, reassess every 5 minutes. If the patient is stable, reassess every 15 minutes. The patient experiencing a suspected allergic reaction should be monitored with vigilance because deterioration of the patient's condition can be rapid and fatal. Monitor the patient's anxiety level and mental status. Watch for signs of shock and treat immediately if present. Interventions. Treatment is determined by the severity of the reaction. Mild reactions may require only supportive care and monitoring. Anaphylaxis requires more aggressive treatment, including epinephrine and ventilatory support. In either case, the patient should be transported to a medical facility for further evaluation. Recheck your interventions. You may need to give more than one injection of epinephrine. Be sure to consult medical control before administering subsequent doses. Even if the patient is experiencing relief, transport to the emergency department is still warranted because the medication's effect will wear off and symptoms will return. Communication and documentation. Documentation should include signs and symptoms found during the assessment, reasons why you chose to provide the care that you did, the patient's response to the treatment. Emergency medical care of immunologic emergencies. If the patient appears to be having a severe allergic reaction for anaphylactic reaction, administer BLS and provide prompt transport to the hospital. If a stinger is present, scrape the skin with the edge of a sharp, stiff object such as a credit card. Do not use tweezers or forceps. Gently wash the area with soap or mild antiseptic. Remove jewelry from the area before swelling begins. Position the injection site slightly below the level of the heart. Apply ice or cold packs to the area, but not directly on the skin and not for more than 10 minutes at a time. Be alert for signs of airway swelling and other signs of anaphylaxis, such as nausea, vomiting, and abdominal cramps. Place the patient in the supine position as indicated and give oxygen if needed. Monitor the patient's vital signs and be prepared to provide further support as needed. Epinephrine is a sympathomimetic hormone. It mimics the sympathetic fight or flight response. It has various properties that cause the blood vessels to constrict, which reverses vasodilation and hypotension. Other properties of epinephrine include cardiac contractility and relieve bronchospasm in the lungs. It can rapidly reverse the effects of anaphylaxis. Epinephrine is prescribed by a physician and comes pre-closed in an automatic epinephrine injector, also known as an EpiPen. Some EMS systems are authorized to carry epinephrine as part of their regular onboard medications, and in others, EMS providers may be permitted to help patients self-administer their own medication. Refer to your local protocols or consult online medical control. All allergy or allergic emergency kits should contain a prepared auto-injectable syringe of epinephrine. The adult EpiPen system delivers 0.3 milligrams of epinephrine via a spring-loaded needle and syringe system, and the infant child system delivers a 0.15 milligram. If the medication has expired or is discolored, do not give the medication. Inform medical control and continue to provide emergency transport. See Skill Drill 20-1 on how to use an EpiPen auto-injector. Epinephrine can have an effect within 1 minute, so it is the primary way to save the life of someone with a severe anaphylactic reaction. Because epinephrine constricts blood vessels, it may cause the patient's blood pressure to rise significantly. Other side effects include increased pulse rate, anxiety, cardiac arrhythmia, pallor, dizziness, chest pain, headache, nausea, and vomiting. Patients without signs of respiratory compromise or hypotension, make sure that you pay attention to that. Respiratory compromise or hypotension, and who do not meet the criteria of diagnosis of anaphylaxis should not be given epinephrine. Some areas may allow administration of epinephrine by intramuscular injection. With IM epinephrine injection, the concentration must be 1 to 1,000. Find out if your protocols allow for epinephrine IM injection. Okay, let's review everything we covered so far in this chapter. Question number 1. The signs and symptoms of an allergic reaction are caused by the release of A. histamine, B. epinephrine, C. leukotrienes, and D. both histamine and leukotrienes. This one should be pretty easy. And it is D. The two chief chemicals released by the body that result in the signs and symptoms of an allergic reaction are histamines and leukotrienes. Epinephrine or adrenaline is used to treat allergic reactions. Glucagon is a hormone secreted by the pancreas that helps control metabolism. Let's look at the incorrect answers. The signs and symptoms of an allergic reaction are caused by the release of A. histamine. That's partially incorrect. Histamine is a chemical that, along with leukotrienes, is released to cause an allergic reaction, but it's only one of the two things that are released. Epinephrine is actually used to treat anaphylaxis. Number 3, leukotrienes. That's the other thing that's secreted. Leukotrienes are a chemical that's released along with histamine to cause an allergic reaction. So the correct answer is D, both histamine and leukotrienes. Question 2. The negative effects associated with anaphylactic shock are the result of A. severe internal fluid loss, B. inadequate pumping of the heart, C. vasodilation and bronchoconstriction, or D. the nervous system's release of adrenaline. And the answer is C. Anaphylaxis is an extreme allergic reaction that is life-threatening and involves multiple organ systems. In severe cases, anaphylaxis can rapidly result in death. One of the most common signs of anaphylaxis is wheezing, which is a high-pitched whistling breath sound that is typically heard on expiration, usually resulting from bronchospasm or bronchoconstriction and increased mucus production. Let's look at the incorrect answer. The negative effects associated with anaphylactic shock are the result of A. Severe internal fluid loss. The body does not lose fluid. Blood pools in the dilated circulatory system and causes less blood flow back to the heart. So that's incorrect. B. Inadequate pumping of the heart. Inadequate pumping is not the problem. The cardiac output is decreased due to poor return of blood to the heart. So that's the incorrect answer. C. Vasodilation and bronchoconstriction. That is the correct answer. D. The nervous system's release of adrenaline. Adrenaline is actually the treatment for anaphylaxis. The nervous system doesn't release it. It has to be administered. Number 3. You were called to a local baseball park for a 23-year-old man with difficulty breathing. He states that he ate a package of peanuts approximately 30 minutes ago and denies any allergies or past medical history. Your assessment reveals widespread urticaria, tachycardia, and a BP of 90/60 milligrams of mercury. You can hear him, millimeters of mercury, You can hear him wheezing even without a stethoscope. You should be most suspicious of an A, acute asthma attack, B, mild allergic reaction, C, anaphylactic reaction, or D, moderate allergic reaction. This one's very straightforward. You should get it easily. And it is C. The patient's signs and symptoms indicate an anaphylactic reaction. Signs and symptoms of an anaphylactic reaction include difficulty breathing, urticaria, which is hives over large parts of the body, and signs of shock, tachycardia, and hypotension. Certain foods, such as shellfish and nuts, may result in a relatively slow onset of symptoms, but the symptoms can become just as severe. Let's look at the incorrect answers. You're called to a local baseball park for a 23-year-old man with difficulty breathing. He states that he ate a package of peanuts 30 minutes ago and denies any allergies or past medical history. Your assessment reveals widespread urticaria, tachycardia, and a BP of 90/60 millimeters of mercury. You can hear him wheezing even without a stethoscope. You should be most suspicious of A, acute asthma attack. That's not correct. Asthma presents with difficulty breathing, but patients will not have urticaria or hives. B, mild allergic reaction. A mild reaction usually appears with urticaria, itching, and some swelling, but not hypotension and breathing difficulties. C, anaphylactic reaction. That's the correct answer. Or D, moderate allergic reaction. The designation is mild or severe reaction, anaphylaxis, and that's not moderate in this case. It is anaphylaxis. What is a wheal? W-H-E-A-L, a wheal. A, a raised, swollen, well-defined area on the skin. B, an area of localized swelling involving the lips, tongues, and larynx. C, generalized itching or burning that appears as multiple small raised areas on the skin. Or D, an exaggerated immune response to any substance. I hope you paid attention to this part because let's find out what the correct answer is. It is A. Insect stings and bites can cause a wheal, which is a raised, swollen, well-defined area on the skin. There's no specific treatment for these injuries, although applying ice sometimes makes them less irritating. Let's look at the incorrect answer. Obviously, A is the correct answer. A raised, swollen, well-defined area on the skin. B, an area of localized swelling involving the lips, tongues, and larynx. That's actually the definition of angioedema. That's not a wheal. C, generalized itching or burning that appears as multiple small raised areas on the skin. That's the definition of urticaria, not a wheal. D, an exaggerated immune response to any substance. This is the definition of an allergic reaction. It's not a wheal. 5. You are treating a woman who was stung numerous times by hornets. On assessment, you note that some of the stingers are still embedded in her skin. You should A, leave the stingers in place, B, scrape the stingers from her skin, C, pull the stingers out with tweezers, or D, cover the stings with tight dressings? The correct answer is B. Because of the venom left in the sac located at the end of the stinger, you should not grab the stinger in an attempt to remove them. Instead, scrape them off with a rigid object such as a credit card. Let's look at the incorrect answers. A, leave the stingers in place. The stinger will continue to inject venom even when the stinger is no longer attached to the insect. So that's incorrect. B, scrape the stingers from your skin. That's the correct answer. C, pull the stingers out with tweezers. Using tweezers may squeeze more venom into the patient. Or D, cover the stings with tight dressings. You remove the stingers. Do not leave them in place. 6. A young male is experiencing signs and symptoms of anaphylactic shock after being stung by a scorpion. His level of consciousness is diminished, his breathing is severely labored, and you can hear inspiratory stridor, and his face is cyanotic. The patient has a prescribed epinephrine autoinjector. What should you do first? A, assist him in administering his epinephrine. B, apply high-flow oxygen via a non-rebreathing mask. C, provide ventilatory assistance with a bag valve mask. Or D, elevate his legs and cover him with a warm blanket. This one should be pretty straightforward. C, the patient is not breathing adequately, as noted by his decreased level of consciousness, severely labored breathing, inspiratory stridor, and cyanosis. Therefore, you should first assist his ventilations with a bag valve mask. He clearly requires epinephrine, but not before restoring adequate breathing first. Regardless of the situation, a patient's airway must be patent, and his or her breathing must remain adequate at all times. Remember your ABCs. Always airway first. The incorrect answers. A, assist him in administering his epinephrine. That's not part of the treatment, and actually it is part of the treatment, but only after his breathing has been addressed. B, apply high-flow oxygen via a non-rebreathing mask. In this case, his respirations need assistance due to labored breathing and a diminished level of consciousness. So he needs assistance with his breathing. C, provide ventilatory assistance with a bag valve mask. That's the correct answer. D, elevate his legs and cover him with a warm blanket. You should treat for shock, but remember, breathing, airway is the first priority. 7. The most reliable indicator of upper airway swelling during a severe allergic reaction is stridor, anxiety, cyanosis, or wheezing. The answer is A. Stridor is a high-pitched sound that is most often heard during inhalation. It indicates swelling of the upper airway. Wheezing, a whistling sound, is caused by narrowed bronchioles. It indicates narrowing or swelling of the lower airway. Anxiety and cyanosis can occur from a variety of causes, but they are not exclusive to airway swelling. Let's look at the incorrect answers. A, stridor is the correct answer. B, anxiety. This is typically a symptom of hypoxia or decreased oxygenation to the brain. First thing you need to deal with is the stridor, the airway, remember? C, cyanosis. This is a sign of hypoxia and inadequate tissue perfusion. And again, airway is your top priority. Wheezing. This is a sign of lower airway constriction or narrowing. You got to deal with the stridor and upper airway first. Number 8, the most common trigger of anaphylaxis is plants, chemicals, medications, or food. The answer is D. Foods such as shellfish and peanuts are the most common triggers of anaphylaxis. These foods account for 30% of deaths from anaphylaxis, especially in adolescents and young adults. Let's look at the incorrect answers. Plants. Although plants can cause a severe anaphylactic reaction, they are a less common trigger compared to food. Chemicals. While several chemicals can cause a severe anaphylactic reaction, they do not lead to as many as food. C, medications. Medications are the second most common source of anaphylactic reactions. but the correct answer is D, food. That's the most common trigger of anaphylaxis. Number 9, the adult EpiPen system delivers blank milligrams of epinephrine, and the infant child system delivers blank milligrams. A, 0.15 and 0.3. B, 0.3 and 0.15. C is 0.15 and 0.5. And D is 0.5 and 0.2. This one should be fairly easy for you to remember. The answer is B. The adult EpiPen delivers 0.3 milligrams of epinephrine via an automatic needle and syringe system. The infant child system delivers 0.15. And since we covered that, and to prevent confusion, I'm not going to go over the wrong answers here. Just remember the correct answer is adults, 0.3 milligrams of epinephrine, and in child or infant child, 0.15 is the correct dosage of epinephrine. When administering epinephrine by autoinjector, the EMT should hold the injector in place for A, 5 seconds, B, 10 seconds, C, 20 seconds, or D, 30 seconds. The answer is B. When administering epinephrine via autoinjector, push the injector firmly against the thigh until it activates. Hold the injector in place for 10 seconds to ensure that all the medication is injected. Let's go over the incorrect answer. 5 seconds is not enough for the medicine to enter the system properly. B, 10 seconds is the correct answer. C, 20 seconds is too long. The injector should be in place for 10 seconds. And 30 seconds is again too long. The injector should be held in place for 10 seconds for all the medicine to enter the bloodstream. Okay, class, thank you so much for listening, and hopefully you will take this and review your text with it. If you have any confusion about anything, please see your instructor. And I always suggest, as I do every chapter, that you get together with a study group and review some of these signs of anaphylaxis. It's tricky to treat and sometimes tricky to identify. The key is knowing when to call ALS, and always remember that airway is your most important priority. Thank you for your time and attention, and we'll see you next class.